So I'm going to do three things in this presentation. First, just give you a brief background of Kickstart program and our evaluation. Second, outline some of the design innovations and the pathways that we're exploring. And then finally, give you some of our preliminary findings and early lessons learned for this evaluation. So to begin, Kickstart International is a social enterprise, a nonprofit organization that's dedicated to advancing solutions to social problems using a market-driven approach to development. Their primary objective is to alleviate poverty in sub-Saharan Africa. So about 20 years ago, they began selling irrigation pumps and other productive assets. Currently, they have now sold to 150,000 farmers in 20 different countries of sub-Saharan Africa. Their approach was and continues to be using a business model in which farmers, primarily women, purchase pumps from local suppliers. NGOs also purchase and distribute the pumps. The human-powered irrigation pumps range from the small hip pumps, which cost about $35 to the super moneymaker pump, which costs $100. So years of observation, anecdotal evidence, and internal performance monitoring showed that there was tremendous potential for impact, extending even beyond poverty into the realms of education, health, and nutrition. In recent years, Kickstart recognized the importance of an external evaluation. So in 2009, they partnered with IFPRI and Washington University in St. Louis to conduct this evaluation. Funding was received from 3IE, Gates Foundation, and Voxtra. Now, the primary intent of the Kickstart evaluation is to look at poverty reduction. However, it is also uniquely designed to examine the health and nutrition impacts of an irrigation pump. It's a 3-year longitudinal study looking at the differences in pump ownership between control and intervention groups. The first innovation actually lies in the construction of the intervention and control groups. So, similar to others in the social enterprise field, Kickstart implicitly places value in particular characteristics of their clients or the small farmers. So in particular, they place value in the entrepreneurial spirit and a willingness to invest in an agricultural input. Thus, during the planning phase, a great deal of attention was focused on constructing the comparison and the control group. And it was the control group that gave us the most difficulty. We ultimately decided that we would use a group of farmers who had recently purchased the pumps but had not yet realized the benefits to be our control group. So very simply defined, the control group includes 2 cohorts of late pump buyers, and the intervention group includes 2 cohorts of early pump buyers, one owning the pump for 1 year and one owning the pump for 2 years. Another novel feature of the evaluation is that we are using cell phone technology and EpiSurveyor software. We're putting in GPS coordinates to be used for later use in analyses, including like the social networking analysis we'll be doing. The 2 main pathways that we're looking at for positive health and nutrition outcomes are the following. Pump ownership, leading to increased food and agricultural production, leading to increased income and assets. This then may lead to improved health behaviors, such as purchasing of water treatment supplies like WaterGuard or the purchase of ITNs. We're examining all of that. Increases in household and child consumption, and then ultimately on children under 5 anthropometric outcomes. We're looking at the second pathway, which I think is an interesting pathway. We think that pump ownership could actually be increasing water supply for use for domestic purposes, so that then in turn leads to better hygiene and sanitation practices and ultimately decreases in infectious diseases. On the negative side, poor water management is a pathway we're examining for malarial outcomes, both at the homestead and at the plots. We're looking at a range of factors, including agricultural production, irrigated rain-fed livestock, assets, rural services, sanitation, water use and hygiene, mental health and aspirations, household food consumption, young child food consumption, and anthropometry, and morbidities, especially the morbidities related to water and sanitation, so diarrheal outcomes, respiratory infection, trachoma, and guinea worm. Now, I'm going to present a few of the preliminary findings with the caveat that the data cleaning is still going on, and then conclude with some of the early lessons. So in our view, these findings do suggest the possibility that some of these pathways could be, in fact, occurring. The baseline data has been collected for cohort 1. We have 1,264 households, 614 from Kenya and 650 from Tanzania, and 458 children less than 5 years of age. We found that in the dry season, people are in fact using a water source far from the homestead for domestic purposes, allowing for the possibility that the pumps could improve water access. So 13% are using a natural spring or stream, and 11% a public well. Few households reported using the pump yet for domestic purposes, unfortunately, but only half had put it into use yet for irrigation. This is the baseline. The average time to collect water during the dry season was 15 minutes, with a high degree of variability, taking up to 3 hours, allowing for the possibility for labor time savings for women. We did find adult women are the ones primarily responsible for water collection. In terms of health behaviors, only 1/2 of the sample treat water currently. Few use flush toilets, no surprise, 20%, and rely on latrines and nature, again opening the possibility for the pumps to improve sanitation. Household food consumption was greater for cereal, vegetables, legumes when compared to meat, fish, poultry, dairy, and fats. We are hypothesizing this is where a big nutrition change may occur based on the food type demand elasticities. Morbidity prevalences were aligned with demographic and health surveys in these countries, which was heartening in terms of the validity of our measures. 13% of children under 5 had diarrhea in the last 2 weeks, 30% with fever, and 9% with acute respiratory infection. Very few reported cases of trachoma or guinea worm. Now, I conclude with 5 early lessons learned from our evaluation. Number 1, many people are talking about it at the conference, but it really did have a nice effect. The transdisciplinary nature of the study team and our partners, in my view, fostered a lot of innovation and creativity and compromise in the sort of convergence of methods and techniques. All involved partners are working to, this is number 2, are working toward evaluation legacy within Kickstart. And doing that by involving the M&E staff of Kickstart International. Number 3, we think that more pilot testing would have been very helpful for the cell phones in particular, and for the EpiSurveyor. Number 4, the logistical challenges of this large-scale evaluation have been considerable. Reaching these very remote, hard-to-reach communities is important, but it has been very costly and even times dangerous. And finally, we do think that the results from this study may lead to some new thinking and new approaches in agricultural development to improving nutrition and public health. Thank you.